لايف.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. سعد الله مساءكم جميعا. شكرا لمشاركتكم وحضوركم. I would like to welcome everyone in the audience to our second webinar regarding COVID-19 readiness for King Fahad Specialist Hospital in Dammam. Today we have three distinguished speakers with an interest in three topics. We will start, for the sake of the time, we will start with our first speaker, Dr. Mohammed Al-Qahtani. He's a consultant liver transplant surgeon and hepatobiliary surgeon. He's the director of liver multi-organ transplant center, as well as the director of surgical services at King Fahad Specialist Hospital. He will talk about COVID-19 with regard to organ donation. So Dr. Al-Qahtani, thank you for your participation, and the mic is yours. Qahtani, but if you can unmute yourself. Dr. Qahtani, can you share the screen, please?
There is a problem with the internet.
طيب الآن واضح. We can see you. We just want you to share the slides. We can see the last slide now.
Yeah, I have a problem here. Can you please start with another speaker, please, Mohammed, while I sort out what's going on here right now?
طيب. Dr. Hani, are you ready? Dr. Hani?
Yes, sure, I can start.
Yes, so Dr. Hani Hashimi is a consultant hemato-oncologist. He's the director of oncology center at King Fahad Specialist Hospital. And he's gonna talk about COVID-19 and global consensus in oncology. Dr. Hani, the mic is yours.
بسم الله الرحمن الرحيم والصلاة والسلام على سيد المرسلين سيدنا محمد وعلى آله وصحبه أجمعين. First of all, thank you very much for the invitation. And this is a very difficult and tough time on everybody. And I'm hoping that with such webinar, people will be interested in learning about COVID-19 in a very nice and simple way. So just bear with actually the difficulty with streaming. I don't know if you hear me very well, but I'll move through the slide in a okay pace, inshallah.
Yeah, we can hear you.
So my presentation. Okay, so I'll be talking about oncology and malignancy and the COVID situation. Maybe I'll be talking more about how are we doing with it within our region and what we are suggesting and what we're implementing, because everything that we have gone through is brand new. Nobody has ever been in such situation at a global level. So the world today realized that we haven't faced such viral threat in the past 100 years. The standard safety and infection control measure that we've been using for quite some time now are actually deemed insufficient. And more importantly, we need to protect our staff and also our patients. So we need to make sure that whatever we're going to do from now on is going to help our patients and also our staff to stay safe, and safe between two big brackets. So before we start, we just have to acknowledge that Corona is really a tough teacher. It's very, very tough teacher. Unfortunately, we're being forced to learn history and to learn from what we have gone through in an unusual way, in unusual circumstances. And this teacher is asking us to do what's best for our patient and our community. This is helping us big time. The problem is the time that is given to us is very limited. So we had to reflect on our workflow and our experiences. And above all, we have to stay focused on what is important, which is our patients, our family, and our community. So we wanted to make sure that we all stay safe and patients also stay safe. I have a few slides to talk about history. So this is, if you go 100 years ago, people have witnessed something very similar to this pandemic, which was the Spanish flu. It was an influenza pandemic that happened almost more than 100 years ago, 1918. And it unfortunately took life of a huge number of population back then. And back then, we learned so much that social distancing was very important to control such pandemic. And what you see in this slide is very simple way of thinking back 100 years ago, showing Philadelphia and St. Louis. Both of them were hit with this influenza, but St. Louis did very quick social distancing within few days of the first case, whereas Philadelphia took them more than a week to establish, more than 2 weeks to establish social distancing. And you can see cases and deaths in both curves. A lot of us have been actually seeing curves similar to this curve, talking about what is our capacity and what is the healthcare capacity in any country, not to mention a country in specific, but what you're trying to do is actually to maximize the protection and flatten the curve, so you don't exceed the healthcare system capacity in terms of dealing with patients who need active care in ICU setup, for example. To simplify this is actually this actually virus is very contagious. So one person can infect 2.5 people in a 5-day span, and if you talk about 30 days, one person can infect 406 people if you don't do social distancing. And if you do at what they say a little bit of social distancing, this number drops from 406 to 15. And if you do really strict social distancing, you go at 30 days from one infected person to 2.5. So it's very, very, very effective way of dealing with such pandemic. For people who like graphs, so this is what the graph would look like. If you do no social distancing, this is the cumulative curve. And if you do social distancing with 1 day difference between the curve in black and curve in green. So there is 40 more percent cases with 1 day difference only. Moving forward, I'm going to speak more about oncology and oncology setting and what we do in our usual practice. So oncology is a very busy practice. There is actually care that is provided in the clinic. There is care that is provided in the chemotherapy units, care that is provided in day medical surgery for bone marrow and intrathecal therapy and all those things, care that is being taken its place in the emergency department and also in the unit. So it's very, very heavy and hectic place, but we need an effective way to safely decrease the crowd. Social distancing is very important, as we said, for decreasing the risk and rate of infection. The usual oncology practice is very heavy and very, very, very kind of traffic loaded surfaces. So you really need to balance so many things. So you need to balance the patient safety and the patient's outcome, your staff safety and their well-being, also the satisfaction of both our patients and staff as well. And the overall waiting list has to be measured and kept in check in a way that everybody is able to get the best outcome in a very difficult scenario like COVID. So just briefing, oncology patients population is fairly fragile and they're very susceptible to infection because of the nature of the disease itself and because of the treatment that we give to the patients, which is purely myelosuppressive and can affect the immunity of the patients. Those patients live in a very difficult psychological fear to start with the diagnosis, and they are very afraid of contracting under usual circumstances. They're very afraid of contracting an infection from the hospital or from the hospital environment. Think now the magnitude of this stress during this pandemic. So it's actually multiplied by many factors. So those patients now are under extreme social stress because they need some time to come to the hospital. They need some time to come to the hospital and get chemotherapy where immunity is going to be impaired. And they have very difficult medical scenario. They have cancer that they're afraid of the outcome that can be affected with. So as I said before, there is risk factor, disease related. Cancer is a fault of the immune system. So the immune system is not working. That's why the patient gets a cancer in the first place. We give those patients chemotherapy to kill the cancer. So the chemotherapy by itself also cause some damages to the immune system, myelosuppressive, immunity goes down, and the risk of infection goes high. And the business model, the way we actually get the patient to flow within the clinic and the pathway into the, for example, chemotherapy and their inpatient admission pathway, those pathways are actually also puts them at a higher risk of infection, especially during pandemic time. So what I'm trying to share with you in the next few slides is actually how business model can actually improve, decrease the risk of infection and improve outcome in general. So the challenge that we see in our patients is in the clinic, in the inpatients, in the day chemo and in the emergency department. But I'll add to that, there is also challenge that happen in the community for those patients as well, which is unbelievable amount of stress that they have to deal with. So infection control, help in controlling infection. So we learned a lot during this pandemic about controlling the infection and improving our infection control pathways and measures. And I'll share with you a few of them. But with the focus on social distancing. So I'll just focus on social distancing concept in healthcare administration. So it works in the work environment. It works on the workforce and patient safety. In the work environment, it provides safe place for cancer patient to come to. So they know when they enter to the cancer unit, when they enter to the cancer clinics, this environment is actually kept in check, and it's actually fairly safe for them to move around, and it's fairly negative and negative COVID environment. So it's a green zone, as what we call it. It provides also the healthcare worker that cares for those patients with a safe environment as well, because they are actually moving around in this green zone. In terms of workforce, it helped us in actually switching between team A and team B, clustering the services that we're providing site A service and site B service. So it helps in that as well. And our new standard now is virtual. Virtual care is actually becoming a new standard that people are living with. And probably it will also stay after COVID pandemic, and it's actually here to stay. This is not what I'm going to show you. That's it's not a black slide. It's we always have actually a light at the end of the tunnel. So we know that this COVID is scary to everybody, but there is a huge opportunity within it to improve not only the patient and provider safety and outcome, but also it will improve their satisfaction. We're getting a lot of satisfaction feedback from patients who are actually being treated with the new strategies. So I'm listing here 12 things that we've done. We've done more than this, but I wanted to make sure that there is a lot of opportunity for improvement that improve the patient outcome and safety and satisfaction. You can see here that things that has been implemented already are virtual clinic, call center for oncology, CNC, clinical nurse coordinators, hotlines and emergency hotlines, medication dispensing at actually medication is being actually delivered to the patient at their houses with the help of a courier. We have actually already implemented care plans, clinic care plan for patients who lives within quarantine and non-quarantine area, different care flow for the patient from those areas, inpatient care plan and inpatient care flow for patients for quarantine and non-quarantine area. and chemotherapy infusion units established in quarantine and in non-quarantine areas as well. On-call schedule to cater for the patient and their need. A number of clearance forms that has been established and developed by the oncology quality committee, and also some transportation arrangement has been done. So a lot of things has been done, but I'll focus on two things for the rest of my presentation. So I'll address with you the two things. So addressing workplace infection control in COVID pandemic. What I'm going to share with you is an outpatient model for cancer patients. And it's fairly simplified, and it actually looks at quarantine, non-quarantine, and divided patients simply to what we do actually in our real life. So we either have new patients and we have follow-up patients. For the new patient, the story is fairly simple. If they're coming from non-quarantine area, patient will be seen as per scheduled clinic. There is certain clearance form, declaration form that need to be done, but patients will be seen in those clinics. But if they come from a non-quarantine, from a quarantine area, we are going to accept all the emergency and life-threatening and reschedule the new patients that can be seen as regular. For follow-up, as I indicated earlier, the new standard is actually virtual clinics. So patients are being contacted through virtual clinic, whether it's actually phone calls or actually video conference if possible. Messages has been conveyed to the patients and being assessed in a way that patients are happier with it because they don't have to travel from their houses, even if their house is actually just a few minutes away from the hospital. So they're going to stay wherever they are and actually get connected to the healthcare team. The second one is decentralizing care, cancer care during COVID pandemic risk mitigation model. So with this risk mitigation model, we wanted to make sure that we avoid the crowdedness in the chemotherapy units, where patients must come and receive treatment in a hospital facility. So by looking at the population that we serve in our oncology center, we're able to say that we have a number of clusters that we can, patient cluster that we can cater for. One of them was in Al-Hassa, the other one was in Al-Qatif, and a third one was in Hafr al-Batin. And we were able to develop something very similar to what I'm showing you here. This is an example of Al-Hassa outreach clinic, where we provide adult and oncology and adult hematology, pediatric oncology, pediatric and palliative care as well to the patients in those clinics. And it's fairly simplified approach to the patients. So keeping in mind, when we see patients in those units, in those chemotherapy infusion unit, the quality, the infection control rules that we we actually strict with at our site is applied in those satellite outreach clinic, chemotherapy clinic, whether it's in Al-Hassa or in Al-Qatif or in Hafr al-Batin. We provide the same kind of standard for infection control. I'll end with very simple approach to business in oncology. So 3 scenarios that anybody can actually deal with, whether it's a life-threatening, and if it's a life-threatening, we deal with it and we treat the patient as a suspected case of COVID. Typically we do the PCR for the virus, but we provide the full care to the patients with full protection for the healthcare staff. And if it's not life-threatening, it's an urgent case that must be dealt with, so we do the same. So we deal with the patient and we treat the patient as a suspected case. We actually do the swabs for the COVID PCR and treat the patient with a full protection. And if it's routine, our new standard is virtual, but if it's actually something can be delayed to ease the traffic and relax the patient a bit, we delay those clinics. With this, I'll come to the end of my presentation, and this is just some sort of relaxing slide. So this is how my grandfather saved the world back in the World War II. And this is how I think we should save the world, especially those who don't belong to the first line provider of healthcare or security. This is probably how you should save the world. Stay at home, stay safe, and save life. And thank you very much. And I'm happy to take questions.
Thank you, Dr. Hashim, for the outstanding lectures. We will leave the questions to the end of the session, to the Q&A part. I would like to remind all the audience to send their questions to the hashtag on Twitter, Readiness _KFSHD _COVID-19. Our next speaker has been already introduced. For the sake of the time, we can proceed. Dr. Al-Qahtani, again, he's a consultant hepatobiliary and liver transplant surgeon. He's a director of multi-organ transplant center, and he's the director of surgical services at King Fahd Specialist Hospital. He will talk about COVID-19 and organ donation. Dr. Al-Qahtani, the floor is yours.
Okay, thank you so much, and I apologize again for what has happened before. Good evening to everybody. I'll talk about the organ donation and transplantation. I will share a screen. Okay, so the transplant patients are like cancer patients. They are more vulnerable to the COVID-19 infection because they do have chronic disease as well as they are immunosuppressed. Immunosuppressed is a group of patients who are already post-transplant. And it's a new era of COVID-19 pandemic. That's why we don't have a very clear or very well-established guidelines for the organ donation and transplantation. All what have been written actually position statement, recommendations, and it differs from one center to another center. So what are the modes of transmission? I will just go very quickly to give just an idea. It's either donor to recipient, droplet, or respiratory spread. And the other mode is the nosocomial infection, whether it's from the patients, visitor, healthcare providers, surface contamination, or it could be a community-acquired infection. Okay, so the problem with this group of patients who are the transplant patients, they progress to a worst stage of the disease, which is progression to pneumonia, more common than any other patients, and very quick. The rate of admission also to ICU is more compared with the other group of patients. They do have actually greater viral burden and greater infectivity. So just to give an idea about the ethical issues, if you think about the ethical issues, alhamdulillah, we haven't reached to this stage so far in our country, and inshallah will not reach it, inshallah. But look at what has happened in the other countries, European countries. You have a lot of patients, you have a lot of really very sick patients who required ICU admissions. And unfortunately, if you look at the resources, very limited resources. So thinking about the ethical issues, are you going to save those patients with COVID-19 who needs urgent intervention, or are you going to do the transplant? And by doing the transplant, the patients will be more immunocompromised and the risk is higher actually for getting the infection. I'll talk about both kidney transplant as well as the liver transplant. So to make it very easy and very straightforward, although there's nothing straightforward in transplant, but for the kidney transplant, we all know that most of those patients, they will be managed by hemodialysis, and mostly those patients can be delayed for a few months until everything is clear. So most, if not all, of the living donor kidney transplantations, they are elective surgery and they are going to be delayed or postponed. The cadaveric donor transplant, we take it actually case per case, depending on the policy that has been established by the Saudi Center for Organ Transplantation. Just to give an idea, very quickly about the other international experience with transplant. In Spain, they take it case by case, depending on the how sick is the transplant patient, and also the surrounding circumstances, whether they have a lot of COVID-19 patients positive around, requiring more infrastructure or resources, or if those cases can be done without compromising the other resources for COVID-19 positive patients. In Italy, believe it or not, they did continue to do urgent cases of liver transplantation, even in the epidemic areas. Non-epidemic areas, it depends case by case. North America, we all know that the most of the transplant in the North America are cadaveric liver transplant. They do have a good donor pool of cadaveric transplants. Living related, they do it actually for those patients with a very low MILD score. So very low MILD score, that means they can postpone the surgery later on. It's not an urgent transplant to be done. For the cadaveric liver transplant, actually they do it for fulminant liver failure, whether it's for adults or pediatrics, high MILD score, when I say high MILD score, 20 and above, and patients with hepatocellular carcinoma. I went very quickly looking at the other international experience to focus more actually on the national experience. Each center is required to create its own pathway, or I would say recommendations, because again, we don't have a very clear guidelines so far. So the recommendations says that we need to suspend or hold the living donor liver transplant except for the following. First of all, patients with a very high MILD score, which is more than 25, fulminant liver failure, as well as patients with HCC. The disease donor liver transplantation continue as per the Saudi Center for Organ Transplantation, and I will talk about their criteria of selecting the cadaveric donors. Liver transplant recipients, we know, are different from kidney transplant because of availability of hemodialysis, and the other thing is the 90 days mortality of decompensated liver disease. It's very high. If you are talking about MILD sodium score of 20, it reaches up to 19.6%. MILD of 30 is around 52.6%, and MILD 40 is a very high mortality, around 71%. So in the outpatients, we need to limit the outpatient visits, and this has been elaborated very nicely in details by Dr. Al-Hashmi. And we need to limit also the number of family members. So if we need to get the patient after the communication with the clinical nurse coordinators, and the patient has to present physically, we need to get the patient alone without any family members, and the time of visit has to be very limited. Consider what's called visual clinics, virtual clinics or telemedicine. Screen patients over the phone by the clinical nurse coordinator prior to arrival, and again on arrival they will go for visual triage or visual assessments. For the pre-transplant outpatients, we did postpone all kidney transplant patients. So the workup has been held since March 2nd at KFSHD. For the liver, we continued only with the urgent cases, high MILD, and patients with HCC. Very important issues that I need to talk about tonight. Most of the transplant patients, they will think by decreasing the dose of immunosuppression, they will be more protected against COVID-19. So please don't reduce any immunosuppression medications. Just follow the usual precautions like any other group of patients. Minimize also in-person visit and try to avoid the crowded area, good hygiene, and all precautions that have been mentioned by the Ministry of Health. For the symptomatic recipients, it's very important. For example, if we screen the patient over the phone and the patient has symptoms in the form of high fever, dry cough, or shortness of breath, we will ask the patient to come to the hospital Meanwhile, the patient has to be instructed to wear a surgical mask and then to come to the hospital. Upon the arrival, we'll do the history, physical examination, and do the COVID-19 test. If the COVID-19 test is positive, then he will be dealt with, and if it's negative, he will need another assessment. This is the last position statement that has been released by the Saudi Center of Organ Transplantation. This is the second statement. And for patients, for transplant candidates, usually you need to do the COVID-19 test, both oropharyngeal and nasopharyngeal. If it's positive, then the patient will be excluded from having the transplant. If the result is negative and this patient is classified as a low risk, then you proceed with the assessment and transplant. If the patient is from a high risk area, then you need to repeat the test after 4 days. If it's positive, the patients will be declined. If the test is negative, we'll proceed with the transplant. Organ donation, again, I wouldn't elaborate more on this, but this is the Canadian recommendation for the disease donor. Usually they do the COVID-19 test, and only cadaveric donor with the negative COVID-19 test will be accepted as donors. And for the living donor, usually they do 2 tests, and the last test has to be only 24 hours before the transplant. As per the criteria of the Saudi Center of Organ Transplantation, again, this is the second revised position statement. For the deceased donor, you need to do the test twice. It has to be negative twice. It's a very crowded slide, but that's the summary of that. If you have potential diseased donor, you do the test. If it's positive, then the donor will be declined. If it's negative, you have to repeat it again to have 2 negative tests. For the living donors, the same thing. Living donor, they are asymptomatic. You have to do the test. If it's negative, but the patient is from a high-risk area, you need to repeat it for the second time. If the patient is from a low-risk area, you proceed with donation. In our hospital, King Fahad Specialist Hospital in Dammam, we did postpone all living donor kidney transplantation. And for the deceased donor, we take it case by case as per the Scott policy. And we did hold all required pre-operative workup. For the liver, we will resume our liver transplant activity, and based on the following. If you have an urgent cases with MILD score of more than 25 or having hepatocellular carcinoma. For the deceased donor, if the cadaveric donor is from a low-risk area, from an institute with no history of COVID-19 patients admitted at that institute, and if the COVID-19 test is negative, after 2 tests, then the donor will be accepted, but the liver will go to someone who is really in need for liver transplant. For the outpatients, again, decrease the number of patients, utilize the virtual clinic or telemedicine, and actually we succeeded. Almost 85% of patients have been managed this way, and only 15% they need to be seen physically in the clinic. We actually aim to shorten the period of stay. If the patient, for example, need to come to the hospital, we'll take the blood, and the patient will be asked to leave the hospital, and the clinical nurse coordinator will follow the result and immediately contact the physician who's on call, and will deal with the patient as per the outcome of the result. We did actually also, like what Dr. Hani Al-Hashmi has mentioned, we established what's called transplant satellite clinic. For example, Al-Qatif area is a high-risk area, and we have quite a good number of transplant patients from that area. So what we have done, actually, our staff from Qatif area covered that clinic, and all patients will be seen in a primary healthcare center in Qatif area. and the blood will be sent to our lab. The result will be checked by our clinical nurse coordinator, and it will be conducted to the consultant there. And the medications also will be shipped to all patients. That's all almost about the multi-organ transplant center. Only 2 or 3 slides I will talk about the surgical services center. We did actually the same thing. We did reschedule all non-urgent outpatients visit, and we rely mostly on the virtual clinics. We spend actually some time to train the staff, having multiple simulations, whether it's in the OR, interventional radiology for all staff. And we followed actually the usual standard precautions. We established again the same thing, which is the satellite clinic of surgical oncology in Qatif area that's covered by our staff from Qatif. We made sure that the OR is ready. We allocated actually 2 isolation rooms with negative pressures, with all resources needed to operate for suspicious cases as well as positive cases. So the conclusion, the coronavirus disease is rapidly spreading. Adequate resources should be available for COVID-19 patients. No established guidelines, as I have mentioned, for organ donation and transplantation, but what we are following actually is the center experience or the international recommendations. Suspicion of all living donor kidney transplantation, limit the liver transplantation for urgent cases only, utilization of other modalities for outpatients, and reassessment of the current situation every now and then. Thank you so much.
Thank you, Dr. Qahtani, for the excellent talk, and we have enough time for questions and answers, and we will proceed with our third lectures. But before that, I would like to remind the audience to send their questions to our hashtag on Twitter, Readiness_KFSHD_COVID-19. The next and the last lectures for today's webinar will be presented by Dr. Raida Al-Baradi. Dr. Raida Al-Baradi is a consultant pediatric neurologist and epileptologist. It's epilepsy consultant. She is going to talk about COVID-19 and the impact of COVID-19 with regard to a neuroscience patient. So Dr. Raida, the mic is yours.
Okay, thank you very much, Dr. Muhammad, for kind introduction. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. So today I'm going to talk about the latest update of the pandemic effect on the neuroscience. My talk is going to be divided into the first part. We'll talk about what are the recent published neurological manifestation for patients who had COVID-19. And then the second part, I'll talk about the readiness that has been done in the Neuroscience Center at King Fahad Specialist Hospital, Dammam. Interestingly, in the past, there is nothing was mentioned about the neurological manifestation of COVID-19, and everybody were thinking that it is only respiratory. And I think till now, I can say we know almost nothing about the potential interaction between COVID-19 and nervous system. However, the recent published articles, which occurred over the last only few weeks, we start to learn a little bit about it. So I know that yesterday Dr. Imam and Dr. Hadi talked about the virus itself, but I will talk a little bit about the virus, which can help us to understand what the relationship of the virus and how it affects the central nervous system. So everybody knows that coronavirus are enveloped virus with positive single-stranded RNA genome. They are classified as 4 genera: alpha, beta, gamma, and delta. Alpha and beta and delta infect mammals, whereas delta and gamma infect avian species. The virus has the ability to jump between species, leading to the emergence of MERS, caused by MERS coronavirus, SARS, caused by SARS coronavirus 1, and COVID-19, caused by SARS virus 2, with deadly consequences. And it was thought that this, the jumping between the species may affect the severity of the disease in various patients. And interestingly, to date, can you imagine that we have 8 human coronavirus identified, and each one has different severity and different affection in the to the human. And you can notice in this slide that the various types of coronavirus and its receptors, which is very important and has important link to the nervous system, where the receptors are angiotensin converting enzyme 2.
So right, we can share the slide.
Oh, sorry. No, it happened. Can you see it now?
Yes.
Okay, sorry for that. So, as I mentioned, the various types of the coronavirus has receptors. The most common one is angiotensin converting enzyme. And the virus is called corona because from the corona is the horn. So they have horns that is attached to the receptors, mainly angiotensin converting enzyme, and has the propensity to affect the cells in various organs of the body, including the endothelium of the vessels, central nervous system, and intral part. And this paper was published only in April 3rd, showing various neurological manifestations in 64 patients. 6 patients were excluded from the study because they were continued to be in mechanical ventilation and sedated, and a neurological examination was not done. So they remained with 58 patients. And out of these 58 patients, you can see 16 patients, they have high temperature. Mental status changes was noticed in 65%, agitation in 69%, and cortex spinal tract, including spasticity, hyperreflexia, positive clonus in 65%, and dissociative syndrome in 36%. Brain imaging was done in some patients. In 13 patients, 62% had leptomeningeal enhancement, and all of the 11 patients who were imaged showed perfusion abnormalities, and in 23% had ischemic stroke. Interestingly, CSF was done in 7 patients out of these 58 patients, and 2 of them had oligoclonal band and 1 had elevated IgG. These 2 patients are different. here, this is in the previous clinical manifestation were in France, Starbong Hospital, and it was, as I mentioned, published only on 3rd of April. This is one of the largest series of patients in Wuhan, China, where 214 patients were published. And you can see here the age were more in those who are younger than more than 50 years old, and the severity is more severe in elder patients. Male and female are have similar severity, and they describe the comorbidities. Patient who had hypertension, diabetes, cardiovascular disease has severe disease compared to those who did not have these comorbidities. And I will not talk about the typical symptoms because it was already mentioned yesterday. I'll focus about in a large series in neurological manifestation, and they divide the neurological manifestation into central nervous system, and they mean with that is impaired consciousness, stroke, ataxia, seizure. And then other group is peripheral nervous system, including impairment of the taste, smell, and vision, and skeletal muscle injury. So patient who had neurological manifestation in general were around 36%. Out of these, those who had a neurological manifestation were more in who had severe disease. The most common neurological manifestation is dizziness and headache, 24 dizziness and 16% headache, and the others neurological manifestation were noticed. Notice that stroke was seen in 2.8%. We'll talk more about the stroke in a minute. Peripheral nervous system, including impairment of the taste, smell, and vision, was noticed in around 5%, and skeletal injury, including rhabdomyolysis, was noted in 10%. Interestingly, these symptoms, especially in the central nervous system, occurred within first 1 to 4 weeks, whereas in peripheral nervous system occurred in the first week after the illness. So I will talk in more detail about the acute neurological manifestation of coronavirus, including para-infectious or post-infectious. Let us start with para-infectious complication. Anosmia or loss of smell is common, and in most cases is transient, and few of them can be permanent. Most of them are accompanied by ageusia, which is loss of taste. Why this is important? These patients probably they lose the smell because the virus invade the olfactory pathway, and this is considered to be serious. That's why these patients who had anosmia need to be monitored very carefully because they may develop encephalitis. Following these patients is very important till they regain their usual healthy status. Myalgia can occur at any time during the course, which can persist after recovery of other symptoms. Occasionally, rhabdomyolysis can be serious, can affect the renal as well as the other systems. So, will hydration to these patients should be done. Meningitis is also seen in some cases. Headache is the most common complaint. However, if the patient, if you notice in the series, headache was noticed in around 15%. Those who had headache is not known if they have SARS coronavirus invasion to the cerebrospinal fluid, or if they have signs of aseptic meningitis or viral meningitis. The virus itself has been detected in the cerebrospinal fluid in SARS coronavirus 2 in infected patients, and in SARS coronavirus 1 has been detected in the cerebrospinal fluid of patient with encephalitis, as well as acute respiratory distress syndrome. So patient may have acute respiratory distress syndrome, and you may find some CSF abnormalities. Initially, when patient had mental status changes and go into coma, they were thinking this might be related to the hypoxia and multi-organ failure. However, direct invasion of the central nervous system start to evolve, and some cases start to be reported. A case of SARS coronavirus 2 meningoencephalitis has been reported from Japan, and the patient presented with generalized seizure, paranasal sinuses, lesion of the temporal lobe, as you can see here, and adjoining ventriculitis, and lesion of the paranasal sinus. And in this patient, the virus could be detected in CSF, but interestingly, it was not detected in the nasal swab. So they may have COVID-19 negative nasal swab, but they can have the virus detected in the CSF, and they can have mild leukocytosis. So another case of encephalitis was reported from China, where the patient developed coma and generalized seizure. He had acute respiratory distress syndrome, and virus was isolated and sequenced from the cerebrospinal fluid. There are another series of 8 patients where the virus was isolated from autopsies and electron microscopy with real-time RT-PCR, and the signal were confined to the cytoplasm of numerous neurons in hypothalamus and the cortex, as you can see here. In addition to that, patients who had encephalitis, they can have edema and scattered increased signal intensity in the brain. And in the past, MERS can cause severe acute disseminated encephalomyelitis and vasculopathy, and fatal encephalitis can occur in immune-compromised patients with HCOV-OV43. In these patients, infected neurons has been demonstrated in the autopsy. What about stroke? Stroke, they start to see patients. The initial presentation is just a stroke without the common symptoms that occur where patient will have fever, cough, and so. So it's nowadays with the pandemic, especially in young patients who present acute stroke, it's important to test the virus, and there are reported cases came to be positive. So a patient with SARS coronavirus 2 and 1 developed hypercoagulable syndrome, and both arterial and venous inclusion in the vasculature, elevated D dimer, and increased BT and BTT and DIC, which make the risk for them to develop stroke is high. Another risk factor for the stroke is elderly who had underlying cardiovascular disease and developed vascular occlusion syndrome like stroke and DVT. Some patients have been reported to develop myocarditis, which is another risk factor for stroke. However, as I mentioned, patient can interesting thing is, as I mentioned earlier, which play important role in neurological manifestation, is the virus receptors to angiotensin converting enzyme. So if the patient, for example, is hypertensive and he's receiving angiotensin converting enzyme medication, the risk for and the predilection for the cells to have the infection is higher. Metabolic encephalopathy develop in acute respiratory distress and often alteration in mentation and level of consciousness. This could be attributed to hypoxia and multi-organ failure, and most patients recover from infection, seem also regain their cognitive status. The long term is not known. Post-infectious complication, ADEM, acute demyelinating encephalomyelitis, we had a few reported cases recently. We know that ADEM can occur in any post-viral infection, and it was thought that patients who had acute symptoms, cough and fever, after 1 or 2 weeks can develop massive inflammation of the lung and cause other respiratory distress syndrome. Similarly, extensive inflammation of the brain and cerebral and spinal cord has been described in some patients, and similar syndrome occurred in COVID-19 patients. Acute necrotizing hemorrhagic encephalitis, which is very fearful complication. Usually we see it after influenza, and recently there are reported cases occur after COVID-19, and it's thought that because of the release of cytokines and interleukins cause damage to the central nervous system. A case was described, as I mentioned, you can see it here, who had thalamic and temporal loop inpatient presented with several days after acute mental status changes and found to have COVID-19. In addition, more reported cases start to be published that COVID-19 can cause transverse myelitis. In this patient who was 66 years old, who had typical COVID-19 symptoms and then developed weakness and bowel bladder incontinence, sensory level. This particular patient, LB and MRI was not done, so they were not able to differentiate if this is Guillain Barré syndrome or transverse myelitis. He was treated with various medication, antiviral, antibiotics, IVIG, and dexamethasone. Unfortunately, he had minimal improvement upon discharge. Also, Guillain Barré syndrome was start to appear in these patients. Interestingly, my colleague in Jeddah, he saw a child last week. He's 10 years old, who had COVID-19 positive, and then he started to have ascending paralysis with typical features of Guillain Barré syndrome. So we start to learn more about the virus and its behavior. In terms of the sensory neuropathy, not much has been written about sensory neuropathy and COVID-19 yet, except for some mention of neuralgia. Post-infectious sensory neuropathy manifests with paresthesia, pain, ascending weakness, could be considered as variant of Guillain Barré syndrome. So what if there is risk factor? Does it occur, these neurological problems in severe cases, mild cases? So there are common comorbidities present with more severe manifestation, especially in advanced age, cardiac or respiratory disorder, hypertension, diabetes. And again, the role of angiotensin converting enzyme lead to increased expression of angiotensin converting enzyme, making the cell more vulnerable to infection with the virus. And it affects also the endothelium, cause inflammation and thrombosis to causing stroke and various neurological manifestations. Risk of COVID-19 for patients with neurological disease, we are concerned as neurologists, especially patients who had a neurological disease and they are using immune-mediated or immune suppressant medication to have worse outcome from the disease. What about the long-term consequences of these patients? It is really not known. There are many unanswered questions. It's interesting that children infected with the virus develop only mild symptoms. Could a component of respiratory failure for some patients be due to brainstem involvement? So they will have brainstem involvement and then respiratory failure. What might be the effect on patients with other underlying neurological illness or develop pulmonary complication? If there is permanent lung injury, and if so, can that affect overall neurological health? All of these need a lot of work and research. The problem is that with ethical dilemma. As a neurologist, we are facing some issues. Patients who had neurological disease are unable to advocate for themselves because of the neurological disease, or because the neurological disease, their lives are considered less value. The issue, for example, if we have patients who had Alzheimer and developed COVID-19 infection, and there are limited resources, a limited ventilator, what should we do in these cases? So finally, I'll talk what has been done as readiness for COVID-19 at King Fahad Specialist Hospital, Dammam. Dr. Qahtani and Dr. Hani talked a lot about it. So I will briefly mention, in addition to what they did, that compliance with all COVID-19 related protocols and new policies in the outpatient, inpatient, discharge, surgeries and procedures, virtual clinic, and creating new KPI to make sure the patients receive and answer all of the questions needed, medications and communication, proper communication with the patient, especially those who are in restricted area. They are getting their needed IV medication related to neurological disease, and getting their medication on time, and implementing precautionary and safety measures to patient and staff in the screen area. As everybody know, hand washing, sanitization, mask, gloves, and social distancing. Many steering committee has been done to educate the staff, reassure them about the plans, and based on COVID-19 infection. Also, precaution has been done for some staff who came from abroad and joining the department. In the neuroscience center, I would like really to thank all of the team in the neuroscience center who followed these precautions and policies very carefully. In addition, most of them, they showed interest, and they have been multiple research projects has been sent to IRB, and they start to do research to understand better about the disease. And one of our colleagues, Dr. Yasser Dabbagh, got a grant to conduct studies as we to understand what's the behavior and of COVID-19. In addition, it is very stressful condition to everyone, not only to the staff, but those who are in quarantine and various communities. So COVID-19 coping clinic was started to the staff at King Fahad Specialist Hospital, and as well as outside, and a hotline was created last week, and it is open 24 hours per day. The staff are very enthusiastic to answer any question to anyone inside or outside the hospital. KPI for patient satisfaction, it has been monitored very carefully and weekly to make sure what issues come out from the patient and solving these issues at proper time. So in conclusion, COVID-19 is very stressful virus that really we need to understand more and more about it. It can cause neurological illness. The King Fahad Special Hospital Dammam in the Neuroscience Center are working very hard to make sure that the staff, patients are managed in proper time, and early recognition of the symptoms will alert the neurologist to make early diagnosis and proper management of these patients. Thank you.
All right, thank you for wonderful and thorough and excellent talk. We learned a lot. We learned a lot from all of you today. I'm just would like to ask Dr. Hani Al-Hashimi. And before that, I would like to still remind the audience they can still send their questions to our hashtags on Twitter, Readiness _KFSHD _COVID-19. Dr. Hani Al-Hashimi, how safe and for how long we can delay chemotherapy for patients who have active cancer, and for how long we can delay chemotherapy and for how long we can delay radiotherapy for patients who needs such treatment. Do you hear me?
If I understand the question correctly, we're talking about chemotherapy delay and what is considered safe and what is considered long time of waiting time. To start with, we have to classify patients. So there are patients who are actually getting chemotherapy for what we call it adjuvant, meaning like cancer has been resected and they need the chemotherapy to super ensure that there is no risk of recurrence. And there is chemotherapy that's given before getting a curative surgery, which we call it neoadjuvant. So that's before the surgical curative surgery. And there is a palliative chemotherapy. So the neoadjuvant chemotherapy is something that we typically give to the patients to prepare them for a better surgery. And in such pandemic, this option can be discussed with the patient. Maybe going to surgery might be the best thing to do. And that has to be discussed case by case. As far as adjuvant chemotherapy, which is actually the question that we get all questioned a lot about. So somebody had breast surgery done a couple of weeks ago, and she wants to get her chemotherapy as soon as possible. So those patient population, there is actually a window to work with. So their chemotherapy can be delayed safely between 4 to 6 weeks. Because the surgery, at the typical time, we typically want the patients to get chemotherapy done within 4 to 6 weeks after the surgery. But we know that in such situation, like what we're dealing with, this might be difficult to arrange and organize, especially for patients coming from a distance where chemotherapy needs to be given to them in our site. So 3 to 4 to 6 weeks maximum can be safely done in those adjuvant settings. When it comes to palliative chemotherapy, which is given only for symptoms, this is actually an area where a lot of debate happens. So patients will not benefit from the chemotherapy to be cured, but it will help the symptoms. So we try our best to avoid getting the patient sick during the pandemic time. So chemotherapy comes with actually at a cost. So if you give chemotherapy, those patients will develop cytopenia. They might end up having low count that make them predisposed for any bacterial infection, and they might need to come to the hospital for some sort of treatment. So we try our best to minimize the need to come to the hospital with those chemotherapy. So we do either modify the protocol, adjust the protocol, reduce the protocol in those settings. But for adjuvant and for things like chemotherapy for lymphoma, we typically can actually delay between 2 to 4 weeks. There is one exception in chemotherapy, is actually the life-threatening conditions. If you're talking about acute leukemia, for example, those patients cannot wait, and those are the ones that we talked about, life-threatening and urgent. We typically bring them in for chemotherapy as an inpatient. We have, over the past month at least, we had at least 7 or 8 patients who fulfilled this criteria, and they were actually admitted for those chemotherapy. So in short, there are certain chemotherapy that can be delayed without impacting the outcome that much. And there are certain chemotherapy, especially the life-threatening one, that we cannot wait, and we have to bring the patient in.
And that's applicable for radiotherapy as well? Or?
Same thing apply for radiotherapy. So radiotherapy, there is even a better window for that. If you're talking about palliative, they typically have a hypofractionated protocol. Rather than giving 5 sessions, they give 1 session. So they have certain modifications that they can do in their radiation protocol. So in the time of the pandemic, most of the protocol were actually moved to the hypofractionation. So less doses are given, but more intense. Patient can be delayed safely for 2 to 3 weeks for radiation, even in curative patients.
Thank you. That was wonderful. There's a question for Dr. Qahtani. When can we safely resume living as well as deceased donor organ transplantation in general, whether it's kidney or liver? And is there any additional or added precaution that we should take when we resume such procedures during COVID-19?
Thank you so much. That's really a very good question, Mohammed. Again, I have mentioned this in my presentation before. So for kidney transplantation or those patients with end-stage renal failure, you can delay the surgery. You will maintain them on dialysis, and actually you postpone their surgery until the era of COVID-19. Certain patients of those patients with end-stage renal disease are top urgent, and we take them case per case. For example, patients with loss of vascular access, you cannot delay them. Sometimes, if you have a preemptive patient and the patient does not want to start on dialysis, then you might, explain the risk to the donor and the recipient as well, and you go ahead with kidney transplantation. So for the kidney, it's very clear. Now, for cadaveric donor kidney transplantation, it depends on the location of the donor, whether they are from an institute with COVID-19 patients admitted to, or if the cadaveric donor had some, symptoms before he was diagnosed or she was diagnosed as a brain dead donor. And we do the test. If the test is negative, we'll repeat it for the second time. If the donor has 2 COVID-19 tests negative, then and being from a low risk area, then you might proceed with kidney transplant for urgent cases only. For the liver transplant, we actually need to resume liver transplant for the following. Patients with acute or fulminant liver failure, whether they are adult or pediatrics, you cannot delay them because the mortality actually is very high. Or patients with MILD score more than 20 or 25 because of the mortality. Patients with, as I have mentioned in my presentation, with a MILD score of 40 the mortality goes up to 70%. So you have no other option. Actually, you need to explain the risk to the patients and to go ahead with transplant. Also, patients with hepatocellular carcinoma, those type of patients, you might postpone the surgery for 6 to 8 weeks. But after 8 weeks, you cannot delay them anymore, and you need to go ahead with transplant. Those patients with hepatocellular carcinoma, you might bridge the transplant with other procedures in the form of transarterial chemoembolization or transarterial radioembolization. But again, the recipient has to go through the admission, and this procedure has to be done in the interventional radiology. So to summarize, kidney transplant, you can postpone all procedures except for the top urgent ones. For the liver transplant, for HCC, high multi-score more than 20 or 25, and acute fulminant liver failure.
Nice. And so do we now currently screen every donor, even if he's from a low risk area? Do we screen him for COVID-19? And if they are positive, do you exclude them or not?
Yeah, for the living-related liver transplantation, we need to do the test for both, for the donor as well as for the recipient, and both have to be COVID-19 test negative. If the donor is positive, then it's going to be, or she's going to be declined. So it's a must actually to screen both with the COVID-19 test, and it has to be negative in order to proceed with the transplantation.
Excellent. Dr. Raida, there was an interesting point you mentioned. A patient who comes in with encephalitis or meningitis, and they had the negative nasal swab, but they had positive CSF for COVID-19. How common is this? And do you now do look or test every CSF for COVID-19?
Yeah, it's an interesting point. As I mentioned, really we know little about it, and this it was only in few reported cases. Currently, we have only 3-4 reported cases since COVID-19, and the question come. Some patient who had just respiratory symptoms, and when they did the CSF, they did it only in 7 patients in this large series. And they found that some of them has positive COVID-19. And this is the question will come. Do we need to do it? So what I will think, it need more research. We don't know really. But what I think is the symptoms of the patient, if he had symptoms of encephalopathy, mental status changes, seizures, and so that it is mandatory to do the workup for them, and to consider COVID-19, especially in this pandemic. But in conclusion, the answer is very difficult.
But when you have a patient now, you routinely send CSF for COVID-19. That's a routine now in our hospital.
It's not routine. We're not doing it currently as routine. But if the patient has high fever, cough, and the symptoms suggestive of COVID-19, definitely it should be done as routine for this group of patients. But if the patient currently, my colleague, they told me that patient came with a stroke. He's a young patient. There is no risk factor. And they treated him, but then they said, let us do COVID-19, came to be positive. And here, I think that we need to have more understanding. Shall we do it in this pandemic? If the neurological manifestation is not typical, I would highly recommend to do it, and looking for what are the causes for the complication that we are finding in patients who had COVID-19. And patient who, for example, currently we have only cases with Guillain Barré syndrome reported. The booming of all of these articles at one time, we are in the process of learning the behavior of this virus. Unfortunately, there are like cases. One case reported, which was very interesting when I read about. Patient did not have any symptoms, and she presented with symptoms of Guillain Barré syndrome. And when they went back, they found that she was exposed to a relative who had COVID-19. She did not have symptoms. Probably she was asymptomatic. So I think we need, with this pandemic, to highly suspect it and look for it.
For Dr. Al-Hashimi, so what's your advice for an oncology patient who have some probably a mild upper respiratory tract symptoms? What is it safe for him to present to an emergency department, or should he just call the call center since he's a vulnerable patient? What's your advice? And what do you usually advise your patients if they have mild upper respiratory tract symptoms? Dr. Hani, but you just need to unmute yourself. Can we unmute? Yeah.
Yes. During this time of the year, it's very typical to get an upper respiratory tract infection. And it's very unfortunate that we're dealing with this pandemic during this time. So we have patients who have symptoms, but unfortunately, due to this pandemic fear, everybody who has these symptoms has to be tested. We have tested few of our patients since the start of the pandemic. Few of them came back positive, that I recall maybe 2 patients, but the rest came back negative. But it's something that is very important to guarantee the safety of the patients and also the safety of the zone, the green zone that patient works in. So our advice to patients who do have symptoms at home, if they develop, so first of all, there is a phone hotline that they need for, either the E1 cluster, even through the person, clinical nurse coordinator, so they can contact the coordinator, give them distance, and can be on the phone. And if the score is higher than a specific number in that form, they will be asked to come to the emergency department to get tested and then isolated. There is 2 components of that, because if your patient is actually living with the household, there is a wife, family that might be at risk as well. It's not only the patient. So patient with symptom must be tested. Result in the past few weeks is actually very quick in coming out. So we have the result for patients within less than 48 hours. So the isolation period can be less than that. Treatment for COVID, as everybody knows, it's actually very supportive. So it's a viral infection to start with. So the general mild symptoms are actually treated with a typical supportive management. We avoid admitting patients if we can actually support them at home.
A question to Dr. Raida. There has been some talks about the role of anticoagulation in patients with COVID-19. And as a neurologist, I'm sure you had patients come in with CVA and stroke who would need some form of either thrombolytic treatment or anticoagulation. I don't know, from the literature, have this shown any evidence giving anticoagulation in patients with COVID-19 who comes in with neurological manifestation? Does this improve outcome with regard to COVID-19 in particular?
Yeah, thank you very much for this question. And there are, again, many studies, they were thinking the underlying pathophysiology of COVID-19 is that it causes inflammation to the vasculatures, which can be anywhere in the brain, in the lung, in the various organs. And with this thrombosis, even without a neurological manifestation, if it is only respiratory and causing, they were thinking maybe this is causing thrombosis to the vessels of the lung. And some of studies showing better prognosis. However, I cannot say like it should be used routine. It should be used carefully. In patients who had stroke, it is used anyway as the usual protocol of stroke by TBA, anticoagulation, and so on. But if the patient doesn't have a stroke and have other manifestation, could it be helpful? And there are like some data showing probably it's helpful. And I saw some studies are using it and showing good efficacy and good outcome. However, we need more studies to make comments on it.
Excellent. There is a question for you, Dr. Fahad, regarding the AC inhibitors. And can we use it in order to dysregulate angiotensin-aldosterone system?
Yeah, thank you again for this question. Regarding the virus has receptors in angiotensin converting enzyme, and if we use angiotensin converting enzyme inhibitors, it will affect the receptors, and you don't want to do that because it will make the virus easily and the cells are easily vulnerable to the infection, and it will can cause worsen the infection. So it is recommended, even if the patient is angiotensin converting enzyme inhibitor for hypertension or other causes or cardiac causes, to convert them to other medication like calcium channel blockers, based on the theory of receptors of this COVID-19.
Excellent. Okay. Thank you. I don't think there is any more questions. And we are almost 5 minutes ahead of time, or 4 minutes ahead of time. So I would like to thank all of you for an outstanding and thorough and detailed presentation and lectures. We learned a lot from all of you today. Thank you very much. And we will have our last webinar tomorrow at the same time, 7 p.m. So hopefully we'll meet all of you tomorrow, inshallah. Thank you very much.
Okay, thank you. Thanks.
Thank you very much.